This is some background information for the paediatric airway teaching session. Hopefully by watching this beforehand we can spend more time just doing the practical scenarios on the day. The problem that a lot of people encounter with paediatric airway situations is it's something that we don't deal with very commonly. So it's a very stressful, unfamiliar situation, and there's the extra element of complexity because with different sized children we need to make calculations for drug doses and select appropriately sized pieces of airway equipment, which we wouldn't normally have to do with adult patients. So the solution for this is to use the printouts off the computer and tables in some of the books which just tell you which pieces of equipment and the right drug doses to use for particular patients. And so this avoids the problems of trying to do mental calculations in a stressful situation, which is always going to be a source of error. So one of the things to practice today is just using the appropriate printouts. We're going to talk briefly just a little bit about some of the anatomical and physiological differences with the paediatric airway compared to adults. The differences are greatest in children that are less than 2 years old, and between the age of 2 and up to about 8 years of age, they gradually progress to be more similar to just sort of small adults. One of the reasons why paediatric patients have so many respiratory issues and often get respiratory failure and need respiratory support is just due to the size of or the diameter of their airways and the relative effect or the relative impact of swelling on the area of the airway. So if you look at this example, if a child has got a diameter of 4 millimeters of their trachea and just a total of 1 millimeter of swelling, so half a millimeter on each side, which seems to be a fairly negligible amount of swelling, but decreases the area down to about 56% of what it was, and increases the resistance to flow by 3 times. So they've got to have 3 times as much force driving their ventilation to achieve the same tidal volumes. This is compared to an adult example of an 8 millimeter airway that's reduced to 7, and there the area is still 76% of what it was compared to the 56% in kids, and the resistance has only increased sort of slightly more than 1.5 times instead of 3 times. So you can see that the dramatic difference that having a little bit of swelling on a small airway makes in children compared to adults. When we come to intubating children, there's a few differences to the way we sort of set up for adults. So in adults, we tend to elevate the head on a pillow or some folded up towels to try and get them into the optimal position for intubating. Whereas children, particularly infants and young children, tend to have quite a large sort of occiput to the back of their head is relatively large and will tend to flex their neck forward. So you generally, in small kids, don't need to support the head too much, and in fact sometimes you may even need to put something under the shoulders. As I said before, as they get older, then they progress more towards the adult situation. Next feature, some of the features of the mouth and the airway itself. So children tend to have a relatively larger tongue, taking up a bit more of the space in the mouth, and also the space in the lower jaw that the tongue can be sort of pushed into when we're trying to get it out of the way to get a view with intubation can also be relatively smaller. So the tongue is often in the way and obscuring the view for intubation. And then also the opening to the airway of the larynx in the neck, where we're trying to get the endotracheal tube, is at a relatively higher position in the neck, and also a bit more forward. It's sort of tucked up and under the tongue, so it's really a steeper sort of angle to get around the back of the tongue and then forward into the airway, whereas in a lot of adults it's more of a gentle sort of smoother curve with the opening a bit further down the neck and not so far forward. This is kind of a sideways kind of cutaway view of the epiglottis and then the opening of the larynx, and you can sort of see where the endotracheal tube would go in there. And children have this long, soft epiglottis which can tend to sort of flop down and obscure your view of the vocal cords and where you're trying to get the tube to pass. And so this is a sort of the front-on view you get when you're intubating an inner child, and you sort of get the sense of the epiglottis at the top here kind of being a bit floppy. Another distinguishing feature of the pediatric airways is just about where the narrowest part of the airway is, and this is also involved in this question about cuffed and non-cuffed tubes. So in adults, the narrowest part of the airway is at the vocal cords, but this is not it's not a round opening, so the round tube doesn't sort of seal well at the narrowest point of the airway, and that's why we have a cuff further down to make a seal for the adult tubes. In children, the narrowest point is at the cricord ring, which is essentially a round structure. So if you get the appropriately sized round tube, you can have quite a snug fit there. You'll get just a very small amount of leak, which is okay. So traditionally, people have used uncuffed tubes in children, sometimes up to the age of 8. But there are sort of cuffed tubes that are available now. You may need to use a slightly smaller, so like a half a size smaller cuff tube than the tables or the printout would suggest that you would normally use for an uncuffed tube. And you don't always need to inflate the cuff, so just having the cuff in its deflated state, just sort of bunched around the end of the tube, often provides enough of a seal anyway. And as I said, these in children, it's often quite a snug fit anyway. But the question of whether to use a cuffed or uncuffed tube depends a bit on exactly what the problem is that you're intubating the patient for. So if it's an airway problem, a problem just with sort of swelling in the airway, and there's no real problem with oxygenation, there's no real lung problem, then an uncuffed tube is probably going to be fine. So croup would be an example for that. But if you've actually got a problem with oxygenation and ventilation, you're actually having to need quite high ventilator pressures, maybe some PEEP to help oxygenate the patient, for example, in pneumonia, then in that situation you may want a cuffed tube just to try and minimise the leak and help to optimise the ventilation. Another issue which is more likely to be a challenge in paediatric airways than in adults is they often have quite large tonsils and adenoids, and there's always the risk that this tissue might start bleeding as you're kind of poking around with the tube and the laryngoscope, so you have to be very careful to avoid that, because once they're bleeding, it's going to be very hard to see what's going on. But there is some good news in that paediatric patients don't have the common problems that adults can have that can make an adult airway difficult. So they don't usually have obesity, they don't usually have poor neck mobility, and they don't usually have poor mouth opening. So usually once you get them in position and we're aware of all these other things that I've just talked about, it shouldn't necessarily be too difficult. Like all these things, preparation is obviously the key, so we need to get all the equipment that we'd normally get ready for intubation. So you want to have your suction, you need your bag valve mask that's connected to the oxygen for pre-oxygenating the patient. You may well want a Goodell's or a nasopharyngeal airway, or possibly both, just to help keep the airway open and unobstructed while you're bagging them. You'll need an appropriately sized laryngoscope. Often in children, particularly if they're less than 1 or maybe less than 2, we'll often use a straight blade as opposed to the curved blade, but we'll need a selection of small sized blades for the intubation. Smaller sized bougies are also available, and they can be very helpful in paediatric intubations, just the same as for adults. The McGill's forceps are going to be very important, particularly when we're changing from an oral tube to a nasal tube, to help manipulate the tube into position. And obviously the endotracheal tubes themselves, we've had the discussion about cuffed and uncuffed. Maybe have a selection of sizes, plus or minus half a size from what you think you're going to need. And then you also want to, from the printout or from one of the charts, just decide in advance the depth that it's going to need to be, particularly for the nose. And as well as the tube, you just want to sort of lubricate the tip to help that pass nice and easily. The patient will need all the usual monitoring, and just like with adults, we have the capnography, so the pedicap capnographer, and to help secure the tube. In children, particularly with the nasal intubations, you'll need string, some tink bends, and the tapes, which we're going to go into particularly in the practical session. The drugs for intubation are also on the printouts. Just be aware that you might need some atropine. If you don't, some people give it routinely, some people just have it drawn up and ready to go, but there's a sort of increased risk of bradycardia with paediatric intubations. Another step, as we do with adults, is just to have a backup plan in case you run into difficulty, and paediatric size laryngeal masks are available, and you should just think about what size you need and have one of those handy just in case. After the drugs have been given and you're proceeding to intubation, these are some of the things that you might see sort of on laryngoscopy. So there's a couple of examples here of just looking at the epiglottis, which is the first landmark that you're really going to look for when you're putting in the laryngoscope. Depending on the size and shape of the epiglottis, and also whether it's a straight or a curved blade, you may be able to elevate the epiglottis by pushing into the vallecula, which is the space just above the epiglottis, like in these pictures here, or you may actually put the blade of the laryngoscope underneath the epiglottis and actually pick it up out of the way. And once you elevate the epiglottis out of the way, then you should get a view of the vocal cords. Often at this stage is when you'll pass the bougie through the vocal cords and then pass the tube over the top of that to the appropriate depth. Once you've got the tube in, at this stage you can put the bag on, ventilate the patient through the tube. If it's a cuffed tube, you want to blow the tube up. The next step at this stage is to change the tube to a nasal tube, which is going to be easier to secure in the paediatric patients. So you'll need one of your assistants to hold the tube and continue ventilating the patient while you then get a second lubricated endotracheal tube and then pass it through the nose. And then with the laryngoscope and the McGill's forceps, you're going to manipulate it into position and then get your assistant to take out the oral tube as you advance the nasal tube. As I mentioned here, you want to tie a string onto the nasal tube at the appropriate depth before you start, and you're going to hang on to that. It's going to help you just to hold the whole thing in position while you secure it with the tapes. This is one of the main things we'll be practicing on the day, but the process of taping these nasal tubes in children. So you're going to need two sort of trouser leg pieces of tape and then another piece of tape to go over the top with a sort of slit cut just in the middle. You can see here in the first picture is that string which I mentioned. It's tied at the appropriate length on the tube, and so someone will hold that sort of across the patient's cheeks just to hold the tube in position. Then you want to start with the first of the two trouser leg tapes. Start on the opposite cheek to where the tube is. So in this case the tube's on the right side, so you're going to start on the patient's left cheek. You're going to do what we call the moustache, so put one leg of the tape across the patient's sort of between the upper lip and the nose. Try not to get it stuck on the lip itself, so just between the lip and the nose, and that piece sort of goes across, making a moustache. Then the top sort of trouser leg from that piece goes over the top of the nose and then comes around and then spirals around the nasal tube where it comes out. Then you take the second trouser leg and starting from the opposite side, so in this case starting from the patient's right side, and in this case rather than the moustache, this one, the first one, the top trouser leg runs over the top of the nose and down the other cheek, and then the lower trouser leg on the second side wraps directly around the endotracheal tube as well. And then you get the third piece of tape that just has a little slit in the middle. This is in the fourth picture there, and that goes over the endotracheal tube connector. You'll just have to disconnect for a moment while you put that over, and then that sticks over all the sort of loose ends of the other bits of tape there. I think I didn't mention there that before you start with the tapes, you want to get the Fry's balsam or the tink bends and just put that sort of on that top lip and on the nose and the bits in the cheek there, just to try and help the tapes stick firmly to it. And sometimes you also just get some pieces of comfy or duoderm, just about a couple of centimetres long, for each cheek, just to go under the string so that doesn't cut in too much or cause any problem with the skin on the cheek there. So once that tube's in and it's secured, then other things, just routine things just to think about, is also a nasogastric tube, probably down the other nostril, and then as well as we're just getting a chest x-ray to check the tube position. So hopefully this all just gives a bit more information and background, and that on the teaching day we can pretty much get straight into the practical scenarios. Thanks.